Hello, everyone. My name is Nikki Campagna, and I am a graduate of Concordia. I have been through the FNP program as well as the DNP program. For the past 14 years, I have been working as an oncology nurse practitioner. Actually, I have been doing this since I finished the FNP program. Recently, I relocated to the Henderson, Nevada area from the Midwest there. I had lived in Kenosha, Wisconsin, otherwise for my whole life. Let's get started here. I'm going to be talking to you about oncology and primary care. And just for a little bit of introduction here, wouldn't it be nice if all of the cells in the human body stayed looking like the pretty one in the top row, all perfect and nice? Unfortunately, cells can undergo mutations to the point a malignant cell is formed, as you can see here, multiplies, and starts a cancerous process. And if left undetected, can metastasize to other parts of the body. Prior to moving on to the next slide, I want y'all to take out a little scrap sheet of paper. And any thoughts on how many new cases will be diagnosed in the United States in 2020? Jot down a number on that piece of paper, and then I will change the slide. And just how close were you? Here's the answer. In 2020, an estimated 1,806,950 new cases of cancer will be diagnosed in the United States, and over 600,000 people will die from the disease. We have all of the most common cancers listed here as they are projected to be in 2020. One thing to keep in mind as future primary care providers is the number of people living beyond a cancer diagnosis reached nearly 14.5 million in 2014 and is expected to rise to almost 19 million by 2024. This in itself will have its own set of healthcare needs, which you will come to realize as providers. I just gave you the numbers in the United States, but the fact of the matter is it has become a global healthcare problem as well. Just to give you an idea, cancer is a major health problem worldwide and is the second leading cause of death in the United States. The number of new cancer cases will rise to 22 million within the next 2 decades in the world. More than 60% of the new cancer cases occur in Africa, Asia, and Central and South America. 70% of the world's cancer deaths also occur in these regions. If we do the math, 60% of 22 million equals 13.2 million people of new cancer cases in Africa, Asia, and Central and South America. That is quite a big number when you stop and think about it. You're probably wondering, what are some red flags when you see a patient present that warrant further testing or a referral? As a primary care provider, how do I know if my patient has cancer? There's a variety of symptoms a patient can present with, and not all of it will point to cancer. However, you will know if it does with a thorough workup. And all of these things that I point out here is going to require further workup. Fatigue. Fatigue is so multifactorial. It can point in various different directions, as well as pain, rash and skin changes, a sore that doesn't heal, a fever, change in bowel habits or bladder function, unusual bleeding or discharge, indigestion or trouble swallowing. Just had a few more. Shortness of breath, cough or hoarseness, a mass that can be palpable, and just weight loss without any explanation. Will all of these point to cancer? Not necessarily, but you do have to get to the bottom of all of these presenting symptoms that a patient may come in with. So what is your role as primary care providers? And these are all very general right now, but we'll be getting into more specifics of various cancers as well. The biggest thing is prevention. You should be checking and making sure that your patient is living a healthy lifestyle. You should be screening according to the national guidelines when they're due for colonoscopy, when they're due for mammograms, when they're due for PSA screenings. And you should also be checking a very strong family history. You may become involved with them after cancer diagnosis is made. At that point, you'll be monitoring complications of treatment. If they're done with treatment, the long-term sequelae of treatment, and we'll be getting into this more when we discuss survivorship issues, as well as support for psychosocial issues. Just so you know, not all cancer treatment is in the form of chemotherapy. There is also radiation therapy and surgery. Also, chemotherapy can be oral or IV. A patient that is in active treatment or post-treatment could present to your office with any of these issues, or all of these issues, or one of these issues. But things to pay attention to as potential effects of cancer treatment is fatigue. And the fatigue can occur even long after the treatment is completed. Pain, just because the cancer tumor may have been removed does not mean they're going to be free of pain. Sleep disturbance. This can be physical or psychosocial. Body changes, sexual issues, osteoporosis. Keep in mind your breast cancer patients who are on aromatase inhibitors can be very predisposed to osteoporosis, and they are. So it's very important that they get their DEXA scans done as indicated. Weight changes could be an issue. Balance issues, appetite changes, swelling in legs and arms, better known as lymphedema. This you will see in a lot of mastectomy patients who have had a lot of lymph nodes removed. You don't see this quite as much anymore now that we're going to more lumpectomies rather than mastectomies. You know, the thing with lumpectomy is they take out the tumor and they will just take out a few of the lymph nodes. And before they take out lymph nodes, they define what would be the sentinel lymph node and just really take what they need. When a patient has lumpectomy, just so you know, lumpectomy and radiation will go hand in hand. Whether or not another agent is added to that as far as IV chemotherapy, aromatase inhibitors, is going to depend on the pathology. Mastectomy typically does not involve radiation therapy with it. since all of the breast tissue has been removed. And just to give you a few more potential effects of cancer treatment, of course, fertility issues, coping with grief and loss, and managing difficult emotions, which can be very labile. What we see here is a summary of the frequently seen side effects, and we will get into more detail about a lot of these as we go on throughout these slides. Fatigue is a big side effect with a lot of contributing factors. So all of these have to be evaluated when you're dealing with fatigue. Is it related to pain? Pain can be very exhausting. Is it more emotional distress, sleep disturbance? How are they sleeping? Anemia. And with anemia, we don't just look at hemoglobin and hematocrit. What is their zinc level? What is their copper level? What is their B12 level? Nutrition. How are they eating? Activity. Have they become deconditioned due to their illness? And of course, other comorbidities. There are different ways to approach fatigue depending on the assessment of your patient. And one thing I cannot stress enough is the NCCN guidelines. This pretty much is an oncology Bible, and this is what guides us on treatment options for patients. And when we say this breast cancer patient needs this treatment versus this treatment, we've gotten our recipe, so to speak, and our support from these guidelines. So it's something any one of you can peruse, and actually the subscription is free, and you just sign up online. And they have different suggestions as far as managing a lot of these side effects. And for fatigue, they do talk about gentle exercise, gradually building up, different psychosocial interventions, meditation, aromatherapy, acupuncture, and even yoga. Next, we're moving on to nausea and vomiting. Depending on the chemo regimen and the propensity for nausea and vomiting, we can give any combination of the following, whether it be Zofran, Kytril, Aloxi, Amend, and we always give dexamethasone with it unless there's a reason not to, because dexamethasone does improve the efficacy of the anti-nausea meds. And just keep in mind, nausea and vomiting, there's different types: immediate versus delayed, breakthrough or refractory, and even anticipatory, just thinking about it. We do always medicate with anti-nausea drugs before chemotherapy in hopes of preventing it. And actually, we have been doing very well with that. I have very few patients that truly need to take nausea meds when they leave the treatment room. And I've had very little issues with vomiting. In the event we do have a patient with vomiting, we do bring them back and give them intravenous IV fluids as well as more IV medications, and that seems to help. One thing to mention too, it looks like it's skipped over a slide, but a lot of times we will give a combination of compazine and Zofran while a patient's at home if they're having difficulty managing nausea. They're both from two different families. So since Zofran can be given every 8 hours, what we'll do is give the Zofran 4 hours later, give the compazine, and then 4 hours after that they are due for Zofran again if they need it. Another drug we use is omeprazole as well. And as far as other effects, patient can have diarrhea or constipation. Alopecia is very real with many of the drugs. And for alopecia, if you write a script for the wig, insurance will cover it. And going back to diarrhea, we do treat with Imodium, and we may also use Lamodal if it gets to that point. Constipation, we use Senecot, and if it progresses, we do advance to more laxative type medications. Again, we have anemia here, thrombocytopenia, low platelets, and neutropenia, and that's one of the white blood cells being low. We typically do give colony stimulating factors after chemotherapy, and we'll get into that later, to stimulate the growth of white blood cells. Another side effect is mucositis, and mucositis is the painful inflammation and ulceration of the mucous membranes lining the digestive tract, usually as an adverse effect of chemotherapy and radiation therapy treatment for cancer. Mucositis occurs when cancer treatments break down dividing epithelial cells lining the GI tract, leaving mucosal tissue open to ulceration and infection, which we want to avoid. So we can use things like Gel Clear, Magic Mouthwash, which is a combination of things that the pharmacy mixes. I know there's Benadryl in there, lidocaine, and there is one other medication in there that leaves me at this moment. Another side effect is thrush. Of course, for this we use antifungal. And then also it can be dry mouth or xerostomia. As far as the nutritional status of patients, patients can become cachectic, and this is characterized by a loss of fat and muscle mass, which does not halt or correct with nutritional supplementation. Just so you know, patients can lose weight and not be cachectic. We typically try to prevent this and monitor protein and prealbumin levels and offer stimulants as needed. And recommended stimulants, and these are from the NCCN guidelines again, is Megace, Marinol, steroids help. And one thing you'll find is patients who receive chemotherapy and receive steroids that morning with their anti-nausea meds will have more of an appetite on that day. Other things are fish oil and omega-3 fatty acids, though these have had mixed results. Another thing is Ritalin and also medical marijuana. We do like our patients to have at least 1,200 calories a day if possible and utilize 6 small meals. If they need to get their calories in through smoothies, that is fine. and we look at prealbumin. Prealbumin is a protein that is made in the liver and released in the blood. It helps carry certain hormones that regulate how the body uses energy and other substances throughout the blood. Normal prealbumin is 15 to 36 milligrams per deciliter, or 150 to 360 milligrams per liter. It depends on how your lab measures it. If you have heard patients talk about chemo brain, there truly is such a thing. It is reversible, but it may take months to even rectify it, depending on the treatment, the duration of the treatment, whether it's neoadjuvant, and by this we mean given before surgery, or adjuvant given after surgery, or purely given for the reason of palliative. And a little bit more on chemo brain. Its mechanisms are not very well understood, but it is thought to be due to a variety of things, and one is demyelinization, which is the damage to the protective covering that surrounds the nerve fibers in the brain, as well as a general inflammatory response, and microvascular injury, where disease of the finer blood vessels in the body, including capillaries, are dangerous. And this picture isn't really meant to be funny as a cartoon, because this actually is very realistic. We are now going to change gears from side effects and talk about oncologic emergencies and symptoms patients could come to your office with because they don't realize these symptoms could be related to their cancer, or their cancer hasn't been diagnosed as of yet. Get those scrap pieces of paper out again, and I'm going to show you something here. This is what your patient comes to you with. You do an exam, and when you open his or her shirt, you see distended veins on the chest area, and you do imaging because of this, and you see a very large heart. What do you think you have here? This is what you have, and this is what you see based on the exam you did and the imaging that you ordered. You have superior vena cava syndrome. And what is causing this is a thrombus that is blocking blood flow, as you can see here. Just so you know, cancer patients are more prone to form clots, whether they be DVT or whatever, but they're more prone to clots. So please pay attention to any symptoms that they come to you with that could indicate such. Now in the bottom picture, you could see a stent was placed, and look at the difference of the patient once there is adequate flow. That is the same gentleman in the top picture and the bottom picture. And the first one is when you just had the clot, and the second one is when there's adequate blood flow with a stent being placed. And just so you know, you could have thrombus or mass that is blocking the flow of blood. And then we have another picture of superior vena cava syndrome. And you could see here a right lung mass wrapping around the vena cava and compressing the aorta as well. Now, treatment modalities for superior vena cava in syndrome include chemotherapy, radiation therapy, and endovascular stents in urgent conditions. And just remember that the treatment is going to depend on the histologic diagnosis. And if it is lung cancer, not all lung cancers are alike. Just so you know, there's two categories, small cell, and non-small cell. And then when you're talking about non-small cell, you have adenocarcinoma and squamous cell carcinoma. And it goes back to the saying, tissue is the issue. You need a confirmative diagnosis with a biopsy to distinguish, what type of cancer it is exactly. In general, the purpose of the treatment modalities is to alleviate the symptoms and treat the underlying disease. The severity of the symptoms and the underlying cancer condition, as well as the anticipated response to treatment, guides what initial management you're going to do. At one time, radiation was done emergency, and that no longer is considered necessary for most patients. Again, we go back to histologic diagnosis, and you could see in that one picture that patient did very well with a stent. Supportive care and management of these patients include glucocorticoids and diuretics. And you're going to see this theme throughout these slides, but steroids play a big part in treatment for cancer patients. And now you get a new oncologic emergency. You get a chemistry panel back on the patient, and you see the following metabolic abnormalities: hyperkalemia, hyperphosphatemia, and hypercalcemia. This patient had this done as an outpatient, so he is not sitting in front of you. If he was, he could also have nausea, vomiting, diarrhea. He may complain that he's not been very hungry. You call them into the office to discuss their lab results and to see what is going on and what kind of symptoms they have. And they do confirm nausea, vomiting, diarrhea. They've been very anorexic. They've been losing weight. What do you think is going on with them? A couple other things you may see or hear them complain about is lethargy, blood in the urine. You may examine them and they have indications of heart failure. If you have the ability to do an EKG, they may be having dysrhythmias. They may even be presenting with a seizure to the emergency room. They could be complaining of cramps. They could have issues with tetany. And they could have syncopal issues. They also could have been a code 4 in the emergency department. What do you think it could be based on these clinical manifestations and on the lab results I described to you? What you have here is tumor lysis syndrome. And this is something that we see in people with very bulky disease, when they get that first chemotherapy treatment and they kill off all those cancer cells and everything is greatly reduced in a very short time period, tumor lysis. And that is why you get the effects on the chemistry panel that I had described to you. What we do in these cases is give Elitech or rasburicase, and this is used to treat high levels of uric acid, which can be caused by cancer treatment. Now, keep in mind, some of these patients may not have a cancer diagnosis already, but present with these symptoms and these lab findings. So then it's going to take a bit more to diagnose. I can tell you now up front, patients with very bulky disease that we're going to be starting on chemotherapy and treating for their lymphoma, we generally start them on allopurinol preventative, and really we've had very good results with that and have avoided tumor lysis syndrome. But of course, up front, we've known that they have the cancer diagnosis. And as I mentioned before, this is where you see tumor lysis syndrome. It's in the environment of a malignancy with high proliferative rate, large tumor burden, and or high sensitivity of treatment, initiation of chemotherapy or cytolytic antibiotic therapy. You can even get this just with radiation therapy. And sometimes with the response we could get from steroid therapy, that alone can result in rapid lysis or death of the tumor cells. And for tumor lysis syndrome, these are the cancers that you need to be cautious of. The aggressive non-Hodgkin lymphomas, the acute lymphoblastic leukemias, particularly Burkitt's lymphoma leukemia. And lab values you're going to be finding with these patients, you can see right here, uric acid of greater than 8 or a 25% sudden increase, potassium greater than 6, phosphorus greater than 6.5, for children, or 4.5 for adults, or a 25% increase in a calcium of greater than 7 or 25% increase. So it's always good to look at those lab results as soon as possible. For tumor lysis syndrome treatment, the treatment is based on risk stratification. In general, it boils down to hydrating, monitoring labs closely, making sure the urine stays alkaline, and prophylactic allopurinol when necessary. And actually, any of these patients with bulky disease, we start allopurinol ahead of time for. Also, we do extra hydration in between cycles. So if they're getting treatment every 3 weeks, we usually bring them in weekly for extra hydration. Now, this next emergency in oncology is an easy one and pretty straightforward, so no guessing games with this. Cancer can cause high levels of calcium in different ways, and cancers that affect the bones, such as multiple myeloma or leukemia, and cancer that has spread to the bone, causes the bone to break down, and this releases excess calcium into the blood, and this is how you get hypercalcemia. Hypercalcemia can be mild or severe depending upon where it falls on the continuum, and this just gives you a breakdown of mild, moderate, and severe hypercalcemia. For a patient with hypercalcemia, these are some things that they may be complaining of: constipation, fatigue, depression. They could be very thirsty. They could be dehydrated, low appetite, nausea, muscle weakness, excessive urination, um, confusion, mental status changes may be seen, especially when it's severe hypercalcemia. What we need to do then is to treat the underlying cancer, plenty of hydration. The other thing we do is biphosphonates in the form of permethrin, zoledronic acid, ibandronate, clodronate, and etidronate to strengthen the bone. And just a little note on the serum parathyroid hormone and measuring that in hypercalcemic patients, because there is a higher incidence of hyperparathyroidism. This is the next oncologic emergency that we see many times. And just so you know, the syndrome of inappropriate antidiuretic hormone secretion, or SIADH, or sometimes it's shortened to ADH, is defined by hyponatremia and hypoosmolality resulting from inappropriate continued secretion of ADH despite normal or increased plasma volume, which results in impaired water excretion. The key is that the hyponatremia results from an excess of water rather than deficiency of sodium. There is impaired water excretion causing what is in the bloodstream to be more dilute. And we see this many times in lung cancer patients, especially the small cell lung cancer patients. Now, the interesting thing with SIADH is that there has actually been many patients diagnosed with their cancer because this has appeared first. And this has happened with patients who have gone to the emergency department. They've had sudden confusion. They've run labs on them, see the low sodium. They end up doing scans, and then they find masses in the lung, and ultimately then diagnosed with small cell lung cancer once they do a biopsy. And this just goes through the earliest findings of hyponatremia. And the thing of it is, if left undetected and it falls below 115, you could see eventual seizures, coma, and respiratory arrest. So it's definitely important to keep an eye on these levels. And even when the sodium concentration falls below 120, they could have headache, lethargy, and obtundation, or be mentally dulled. Treatment modalities for this is to treat the cancer. If there is a delay for some reason in treating the cancer, we do need to do fluid restrictions, and this can be difficult for some patients, and it should be less than 1 to 1.5 liters per day that they are taking in. There's also a drug called declamycin that can be used, and this is actually a tetracycline that is used off-label for SIADH. It works by increasing the amount of water in your urine to more normal levels, and this is taken PO and you should notice an increase in the amount of urine within 5 days. Hypertonic saline can also be given, but you really have to manage this very carefully because you don't want to correct it too quickly. So here's a new emergency that I'm going to play the guessing game with you again on. So get out those pieces of paper. Patient comes in with new or worsening back pain, weakness, loss of sensation in affective limbs, decreased proprioception, numbness, tingling, coldness, urinary retention, constipation, or they could have ataxia, spasticity of the bowel, and rather than urinary retention, it's incontinence. What do you think? Give you a second to write it down. This is what is going on with the patient, and what you have is spinal cord compression, and you can see here where cancer has destroyed the vertebrae. You see the normal vertebrae on top and below it, but you can see the compression of the spinal cord and where the tumor has compressed it to the point of destroying the vertebrae. And if the compression is below the level of the conus medullaris, it is called cauda equina syndrome. As you can see from this diagram, the conus medullaris is right around L2. And this is just a rather crude visual, but just so you can see of a spinal cord compression with tumor there. This is how spinal cord compression is typically diagnosed. MRI is the gold standard. The accuracy is 95%. And just so you know, an estimated 25% of patients with spinal cord compression have no bone destruction. That's why x-rays and bone scans are less helpful, and we rely on MRI. As far as treatment options, once again, you see steroids here. You'll notice we use that a lot in oncology. And also radiation. Radiation reduces the size of the tumor, thereby decreasing the pressure on the spinal cord. We also use surgery. Surgery is used if we could safely get to the tumor, which a lot of times we could not in this area. And also pain management, because obviously the patient is in pain with a tumor compressing the spinal cord. And now we have a new problem here. Symptoms include a temperature of 101 and an absolute neutrophil count of less than 500 per millimeter cubed. What do you think this could be? Get out those pieces of paper again and give me a guess. I'll give you a minute and then I'll change the slide. It is febrile neutropenia. And actually, we do see this quite a bit in patients that are receiving treatment, because despite giving like Neulasta and other colonizing stimulating factors, um, it does cause a drop in white count and makes you more susceptible to infection. When we have this, we do make sure we get cultures from different sites. If they have a port, we have to make sure that is included as well. If they have indwelling Foley, the urine needs to be cultured. If they have open skin areas, those need to be cultured. We repeat the blood count. We also look at their kidney function. And if respiratory symptoms are present, of course, get a chest x-ray. They could have a pneumonia that's going on. And we will repeat the ANC and treat the numbers until we get a response. Just so you know, febrile neutropenia is serious business. It's one of the most common complications, as I mentioned before, and it contributes to approximately 50% of the deaths associated with leukemia, lymphoma, and solid tumors as well. And it's typically a bacterial infection that we see, but we're starting to see a few more fungal infections as well. A lot of times when you're looking at a CBC, you may not see an ANC on the results, depending upon how the lab processes, and this is a means of calculating what the ANC is. Also, some labs may refer to granulocytes instead of absolute neutrophils, and those can be completely interchangeable. And then this just goes through the categories of neutropenia, regardless of if it's mild, moderate, severe, or profound. And believe me, we do see a lot of people in that profound range. And keep in mind, it does depend on the unit of measure used by the processing lab. That can vary. So instead of 500 in severe neutropenia, you could very well be seeing 0.5. And then just to mention a term called pancytopenia. And what this is a reduction in red and white blood cells as well as platelets. These are antibiotic options for management of febrile neutropenia. Typically, third-generation cephalosporins are used. Gentamicin or another aminoglycoside is added if the condition is unstable or if the individual appears septic. Beta-lactam antibiotics are usually used in combination with third-generation cephalosporin or an aminoglycoside. Vancomycin is added if methicillin-resistant staph or Corynebacterium species is suspected. If the patient's fever does not respond within 4 to 5 days, or if the fever recurs, even with the administration of broad-spectrum antibiotics after an initial afebrile interval, then we consider adding empiric antifungal coverage to the patient's profile. These are granulocyte colony stimulating factors, which we typically use. Neupogen, also known as Zarsio, excuse me, is used until the ANC reaches 10,000 per millimeter squared. The dosage of Zarsio or Neupogen, and this is something that's ordered by the oncology office, is 5 milligrams per kilogram sub-Q daily according to the duration and severity of ANC. Of course, prior to giving this, you're drawing a CBC so you could see where the ANC is falling. Typically, just so you know, oncology offices are able to process the CBC right there on premises, so we could see immediately before a treatment how patient is doing. The thing with Neupogen is you cannot administer within the 24-hour period prior to chemotherapy. So if you've given Zarsio, you at least have to, and you've gotten the WBC up, you have to make sure it's at least 24 hours before actually giving the dose of chemotherapy. And of course, that the overall condition of the patient warrants it. Typically, if they're on antibiotic therapy, we do not give chemotherapy until the antibiotic therapy is completed. As far as Neupogen, Neupogen is a colony stimulating factor that is given once per chemotherapy cycle. It's typically given the day after chemotherapy. Couple caveats with this is it cannot be given 7 days before chemotherapy because it would be peaking at the exact time chemotherapy is given. It should not be given more than 24 hours after chemotherapy either. So right now there is a product called Neulasta Onpro, and this is something we apply either to the patient's belly or to the arm, and it is a self-injecting device. So it will be applied immediately after chemotherapy so the patient doesn't have to come back the next day. And at that time, there's a very small catheter that goes through the skin when it's applied, and it actually has a timer then to inject the Neulasta the day after chemotherapy. Now, the thing of it is, you probably think, okay, so you can't give it 7 days before chemotherapy. Well, a lot of chemo regimens are weekly. So, unfortunately, these patients cannot receive Neulasta, and if their WBC drops or ANC drops, then their chemo is actually held for a week. And another complication or side effect of treatment, chemo or radiation, is pericardial effusion. And this you see with sometimes left breast masses or sternal masses. And of course, the effusion needs to be reduced if this occurs. Other complications include hypercoagulability syndromes. As I mentioned before, these people are more susceptible to clots. Also, anemia because of the effect on the blood counts, the blood cells. Neuropathy, this is seen with taxanes a lot if they're administered as part of the chemo. Thrombocytopenia, low platelets can reduce. Platelets can be reduced. Also, cachexia and bleeding. Nephrotic syndrome can be a side effect. Also, malignant ascites can occur. And another syndrome called paraneoplastic syndrome. And the list goes on. Just to give you an idea of what paraneoplastic syndrome is about. In a broad sense, what these syndromes are collections of symptoms that result from substances produced by the tumor and occur remotely from the tumor itself. The symptoms may be endocrine, neuromuscular, or musculoskeletal, cardiovascular, cutaneous, hematologic, gastrointestinal, renal, or just very miscellaneous in nature. So that's something that you really have to work on for the diagnosis. And then a little on cardio-oncology. There are certain heart risk factors depending upon the history of the patient and the drug or treatment that they are given. There's non-reversible versus reversible, and that's something that needs to be considered in choosing a treatment for the patient. Also, with any cardiovascular risk, they need a thorough cardiac workup prior to chemotherapy and clearance from the cardiologist. There are not a lot of drugs, but enough to warrant the cardiac screening. A big one is anthracyclines, and these are more non-reversible if these occur. One particular drug in this category is doxorubicin, or known as adriamycin. It's also known as the Red Devil. This is given a lot in breast cancer protocols. This particular drug also has a total life milligrams that can be given. So if a patient receives it once, they will definitely not receive it again. And the whole time that they are receiving the adriamycin, it's a set amount of cycles, and it's specifically calculated to height, weight, and condition. And a close eye is kept on the cumulative dose, just so they don't get very close at all to the total life dose. And then one drug that would fall into the reversible category is Herceptin. This is given to patients who have HER2 positive pathology. Breast cancer patients fill a big population of these of this category. And Herceptin is a monoclonal antibody, and the way Herceptin works is we will do a echocardiogram prior to starting treatment to make sure they have an adequate EF, and it is checked every 3 months then during treatment. Treatment with Herceptin typically is over a year period. And then here's just more specific cardiovascular complications from cancer therapy, those that are related to chemotherapy, and those that are related to radiation therapy. And, you know, when we talk about radiation therapy, these would be the cancers that are typically radiated in the chest area. So in this category, you're going to have esophageal, breast, lung, lymphoma, since that's typically throughout the body. And then here's signs and symptoms of cancer therapy-induced cardiomyopathy. You know, the symptoms are what the patient may be complaining of, and the signs are what we are actually seeing in the patient. So it's important to do a thorough assessment on these people. And again, we had gotten into more specifics as far as cancer therapies implicated in cardiovascular complications. And the chemotherapies, as mentioned before, include cyclines. Also included here is tyrokinase inhibitors, and when you see trastuzumab listed there, that is also the same as Herceptin. We also have Avastin, another monoclonal antibody. And this is one also where you have to pay a close eye to the kidney function. And people who are receiving Avastin should be monitored with urinalysis as well to make sure they do not spill protein. We also have alkylating agents in this category. One particular one is cyclophosphamide or Cytoxan. The interesting thing about this is a lot of times this is given with doxorubicin or adriamycin in a therapy that's called TAX. So that has a taxane, it has adriamycin, and it has cyclophosphamide in it. So just think at the risk for these patients when they're receiving that combination. And I don't know if you remember from before, but a taxane is the one that would predispose someone to neuropathy as well. And as far as radiation therapy, just so you know, mantle therapy is rarely used today. Mantle therapy is field radiation, and it was a type of radiation treatment used for Hodgkin's lymphoma that helped boost cure rates in the 1960s. Radiation was delivered at this time to a large area of neck, chest, and axilla to cover all the main lymph node areas in the upper half of the body. So just think of the exposure there. And as far as radiation therapy, you know, this is pretty self-explanatory as far as benefit versus risk. And I was rather surprised that the first identified cases of radiation-induced heart disease were not until the 1970s. So when you think about it, look how much radiation was used prior to that. So, and here's a little bit on cardiac protection. And again, as far as primary prevention, we talked about a lifetime limit of anthracycline exposure where doses are calculated and a running tally is kept on the patient. Of course, we would use less cardiotoxic agents if there is an indication for that. And then cardioprotectants as well. And it's interesting, but statins reduce the anthracycline induced CHF by 70% in breast cancer patients compared to a control group. And of course, secondary prevention includes adopting a healthy lifestyle, which is important regardless of a cancer diagnosis or not. Aggressive management of modifiable risk factors, you know, your hypertension, your diabetes, obesity, and then pharmacologic intervention with such things as ACE inhibitors and beta blockers. And that also falls into tertiary. Cardiac diagnostic tests that we use includes, you know, various imaging tests, echocardiography, cardiac MRI. And the reason why we like cardiac MRI is that it creates both still and moving pictures of your heart and major vessels. We also will use biomarkers such as BNP to determine severity of heart failure and troponin. Right now, there is a lot of hype about immunotherapy So I do feel that I need to mention this a little bit for you. Just so you know, the way cancer spreads and grows is with tumor cells binding to T cells and then deactivating them. How immunotherapy works is by blocking tumor cells from deactivating the T cells, and it uses your own immune system then to fight the cancer. And when you look out this slide, you will notice traditional treatments, which we spoke of before, and then cancer immunotherapy. Look at the bottom when it looks at intensity of side effects and post-treatment protection. Um, there are more side effects, obviously, with traditional treatments. But and post-treatment protection is a little bit less with chemotherapy because obviously the drug is out of your system. The thing of it is with traditional treatments, it is quicker to work. So if you need an immediate response, you will most likely be getting traditional treatments. And with immunotherapy, though they say that side effects are very low, the intensity of them can be up there because when your immune system is being unleashed to fight the cancer cells, that's when your side effects would include all of the itises. And by that, I mean thyroiditis, colitis, anything that is triggered by inflammation, you can get as a side effect. So people that are on immunotherapy, we are frequently monitoring um, their TSH. They also can get a lot of skin effects from it as well. So that's just something to keep in mind. And it does take more treatments to initially start working. However, post-treatment protection is better because it has unleashed the patient's own immune system to fight the cancer cells. And typically, immunotherapy is not used first line anyway because there's various testing done on the tissue to match up to see if they are a candidate for immunotherapy based on a variety of characteristics in the tumor. And we're going to get into cancer survivors a little bit. And as you can see here, cancer comes in all types and colors. And there are certain principles of cancer survivorship, and not all oncology programs have a survivorship program. So after a certain point, a lot of it falls on primary care. So it's important to be vigilant. Patients still need mammos, still need PAPs, plus, the complications related to cancer treatment need to be treated as well, like long-term therapy with neuropathy, range of motion with some of the breast cancer patients, the emotional side effects, and it really goes on and on. And one thing to reinforce when you're seeing a cancer patient in this point in their life is reinforcing the lifestyle modifications that are needed to prevent secondary cancers and, in general, good health promotion. And here again, I know in the beginning we talked about the effects of cancer treatment. Just want to reiterate these effects because just because the cancer is gone or improving doesn't mean a patient is fine in all other aspects. And if they have metastatic disease, chances are the treatment continues. These are just some specifics on breast cancer survivors. A lot of them, if the cancer is caught in an early stage, and if it's estrogen, progesterone positive when you do the pathology, they're usually placed on tamoxifen if they have not gone through change of life, or aromatase inhibitors if they have. Now, they can also, if they've had mastectomy, have issues with lymphedema. But keep in mind, your patients of tamoxifen can be complaining of a lot of night sweats, hot flashes, increased risk of, and they also have an increased risk of endometrial cancer. So please make sure they are getting their pelvic exams, their pap smears, and of course, if they're having abnormal vaginal bleeding, they need to be thoroughly evaluated. Tamoxifen also has an increased risk of venous thrombosis, while aromatase inhibitors have more of a risk of osteoporosis and cardiovascular disease. So we have to practice good bone health with these patients. And one thing with the night sweats and hot flashes, unfortunately, typically the treatment for that is estrogen, but we would not give estrogen to anybody. And actually, it's not good in general to use estrogen, even if the patient does not have a history of cancer, because it can trigger a cancer. So for these patients, I know a lot of times they're given venlafaxine, but there are some natural ways to combat the hot flashes as well. And one thing we use is hesperidin, and that's a natural type supplement. And the directions for that are just to take as directed on the bottle. Now, genetics play a big part in cancer. And just so you know, fewer than 10% of all breast cancers and less than 15% of ovarian cancers are associated with germline mutations. And the majority of the hereditary breast and ovarian cancers are usually associated with BRCA1 and BRCA2. And the patients who need to be tested for this have the following characteristics or history: multiple breast and or ovarian cancers within a family, 2 or more primary cancers in a single family member, cases of male breast cancer, under the age of 40, and the Ashkenazi Jewish heritage. And the reason why this is very strong in the Ashkenazi Jew heritage is because typically they married within families. And that is how all of that had perpetuated. Another high incident cancer that we should talk about in survivorship is colorectal cancer survivors. And years 1 through 5, we do medical history, physical exam, and we monitor the CEA every 3 to 6 months. This is after they have completed treatment. And what the CEA is, it's a blood test, but it's a protein released by colon cancer if it has become active again. Typically, the normal is under 2.5 for non-smokers and under 5 for smokers. CT scans are usually done every year, and they are followed up with colonoscopy. And actually, they should have colonoscopy done as soon as their therapy is completed, and especially if it wasn't done before diagnosis. And maintenance of healthy weight and an active lifestyle are recommended for secondary prevention. Um, Baby aspirin daily is also known to help in colon cancer patients. And another thing that has come up in the literature is a handful of tree nuts daily for these patients. As far as prostate cancer survivors, we follow these patients up with PSA. And a lot of times patients wondering, why are you getting a PSA on me? My prostate was removed. However, if cancer cells have sloughed off and start growing, we'll be able to detect that with the PSA. Years 2 to 5, we do history and physical exam annually. Digital rectal exam for patients treated with radiation. And they need to have an undetectable PSA to where it's 0. It should truly be nothing. Other things to keep in mind with this patient population, they may be having issues with urinary incontinence, erectile dysfunction, and bowel dysfunction, especially if they've had radiation. So that may require some treatment in the primary care setting long term. A little bit on long-term care of lung cancer survivals. Non-small cell lung cancer patients should have a chest CT with contrast every 6 months for 2 years. And then yearly for the next 2 years, they can do a chest CT without contrast. Just so you know, there is an increased risk for second lung cancer with patients who continue to smoke. Another thing to pay attention to in survivorship of lung cancer patient is radiation pneumonitis. And what this is radiation-induced lung disease. And it is relatively common following radiotherapy for chest wall or intrathoracic malignancies. It has a 10 to 20% incidence. And then I really cannot say enough about nutrition. Achieving and maintaining a healthy weight, getting enough physical activity, and eating a healthy diet can reduce the chance of recurrence and increase the likelihood of disease survival. Enough said. The rest here is just some hints to give patients. And hopefully they will comply with that. 80% of pancreatic cancer patients are diagnosed at stage 4. Only 20% are diagnosed early enough to be a candidate for surgery. He had started chemotherapy right away, had some scans that looked like the cancer was gone. Within a month of the clear PET scan, he had presented with a bowel obstruction, and it was back with a vengeance and in his lungs as well. By November of 2015, he was gone. So I just wanted to share that little story with you, so as to not minimize patient complaints of abdominal pain. It is the 3rd leading cause of cancer-related deaths in the United States. And by 2030, pancreatic cancer will be the 2nd leading cause of cancer-related deaths. In 2020, an estimated 57,600 Americans will be diagnosed with pancreatic cancer, and 47,050 will die from the disease. So it's something to be taken quite seriously, and please, please, please work up your patients that complain of abdominal discomfort. And actually, a lot of the symptoms that a pancreatic cancer patient can present with can be pretty vague, and they mimic a lot of other things that could be going on with the GI tract. It's abdominal and or mid to upper back pain, unexplained weight loss. They can have some nausea or loss of appetite. If there's an obstruction, they could even become jaundice and present with jaundice. Changes in stool can be very oily or watery, and they could also have a sudden onset of diabetes. So something just to keep in mind. And last little thing I want to share with you. This was a poster presentation that I was going to present at an oncology conference in the end of April going into May. However, we know with COVID-19, everything became virtual and I did not get to present. So I just wanted to take a moment to share it with all of you. I'm not going to go into details with the genetic mutations that are listed here. You know, feel free to peruse this closer if you would like. The point of this is that I did do a review and evaluations of studies regarding germline and somatic mutation studies in pancreatic cancer. And you could see all of that posted in column 2. And just so you know, the germline mutation is what is done on the blood. That's where you find the BRCA1 and 2 mutation, as well as many other mutations. As far as somatic mutations, that is done on the tumor itself once it's been excised or, core needle biopsy. As mentioned before, the current standard of care for metastatic pancreatic cancer are comprised of cytotoxic chemotherapies. But despite the recent improvements, the median overall survival for a patient receiving chemotherapy with metastatic disease is still less than 1 year. Recent improvement in next generation sequencing technology have enabled the detection of biomarkers in cell-free DNA, and that has increased treatment opportunities because of that. And one thing that has come out recently is that all pancreatic cancer patients should receive an opportunity for germline testing as well as somatic testing. And this has actually become a standard of care according to the NCCN guidelines. So that's recommended as standard. With increased information about the specificity of this deadly disease incorporating germline testing, more precise treatment can be recommended, improving outcomes. And as I mentioned, the latest NCCN guidelines include germline testing for any patient with confirmed pancreatic cancer. And I cannot say it enough, but germline and somatic mutation testing should be a standard of care for biopsy-confirmed pancreatic adenocarcinoma. One request I have for all of you taking care of pancreatic cancer patients is to make sure the patient and family can access Patient Central at the Pancreatic Cancer Action Network. The reason I recommend this is this particular network is strictly for pancreatic cancer patients, and it attacks pancreatic cancer from all fronts, including research, advocacy, clinical initiatives, and patient services. It will even link a patient up to clinical trials and will also provide a means to get the tumor further tested to see if there is anything out there that will match in treatment. This can be accessed by the patient or family by just calling the phone number listed, and I will give this to you. The print is pretty small here, and it's 877-272-6226. Thank you so much for taking to the time listening to me going on and on. And just so you all know, studies show that patients followed up by a primary care physician and an oncologist have better outcomes than those who follow up left to an oncologist alone. So we are just one big team, and we are there for the patient. Any questions? I know at this point you can't really raise your hand and personally ask me any questions. However, I do have my email up here on the screen. Feel free to email me with any questions or if there's anything I need to clear up for you. Thank you so much for taking the time to learn more about oncology and primary care and how we can all work together as a team. And these are just some references I had alluded to. They are good resources. If you would like to look anything up, NCCN is a free membership, and there's a wealth of information on this website as far as a patient pathway as well. So I hope you all enjoy the program at Concordia. Thank you and have a great day.